Good morning, everybody. I hope you're well. I will try. Thank you. I will try to speak relatively slowly. And normally, if I talk to a patient carer group, all I do is answer questions, okay? So apparently we have to have questions at the end of this session, but I would like lots and lots of questions because I want to answer all the things that you came here today to hear about, because I will speak for about half an hour. The difficulty is I may not talk about the things that you really want to hear. So ask me questions at the end, absolutely, please. So on any subject, I'm quite happy to take questions on many, many different subjects. So this was the title I was given, but I didn't like that title, so I'm going to talk to a version of that title, because what I want to tell you is how much activity is going on to try and produce new drugs for treating Parkinson's disease, or new versions of old drugs. And the objectives I have for this, oh good, it does work, is I want to give you an update on dopaminergic therapy for Parkinson's disease. I want to talk to you a little bit about using other types of drugs, non-dopaminergic drugs, for treating the symptoms of Parkinson's disease. And then I want to just talk a little bit about what we're trying to do, not treating the symptoms, but trying to treat the underlying disease process that occurs in Parkinson's disease. In other words, what steps are we taking towards trying to find a cure for Parkinson's disease? And this is where I'm going to start. This is James Parkinson's views on drugs. When James Parkinson first described the illness 200 years ago, you can probably see from this description here that he really didn't think there was any treatment in the form of drugs available at that time that would have any benefit on the symptoms of the disease. And if he had treated you, he would probably have given you mercury or arsenic or something that I think you probably wouldn't like if it was given to you today. But it was here in the late 1950s and the early 1960s that the first real drug treatment for Parkinson's disease emerged. This man, Ole Hornikewicz, he was the man who discovered that the chemical dopamine was missing in the brain of people with the symptoms of Parkinson's disease. But it was this man, whose name is Arvid Carlsson, he was the first man to show that dopamine could be put back into the brain in Parkinson's disease by administering L-DOPA, levodopa. And this was the start of the pharmacological revolution that we've had in Parkinson's disease for the past 60 years. And this is just a little bit of pharmacology. This is a little bit of science. This is supposed to be a dopamine-producing nerve cell. This is what's called the synapse, and these are dopamine receptors. So that's where dopamine works. And everything we do in Parkinson's disease is aimed either putting dopamine back into the brain by using L-DOPA, or by directly stimulating these dopamine receptors using dopamine agonist drugs. And a dopamine agonist drug would be something like ropinirole or pramipexole. And we have concentrated on this as the basis of treatment for now over half a century, for almost 60 years. And what we have now is this. we have a long list of drugs which are currently available, which can be used to treat the motor symptoms of Parkinson's disease. And basically, there are two groups. On this side, you have L-DOPA and all the drugs which are used to make L-DOPA work better, all the formulations of L-DOPA, and some different routes of administering L-DOPA. On this side, we have the dopamine agonist drugs like ropinirole, pramipexole, so that's Requip and Mirapex, and we have different formulations and delivery systems for the dopamine agonist drugs. Now, you should all be relatively familiar with this because this is standard therapy for Parkinson's disease. Now, you might argue, well, okay, that's fine, but these drugs, they don't work as well as I would like. They don't do everything I want from this type of medication. But you have to think about that almost in reverse. Because if you had Alzheimer's disease, or you had motor neuron disease, or you had Huntington's chorea, there would be no list of drugs like this with which your symptoms could be treated. And we have to be very grateful that we do have highly effective medications for treating some of the symptoms of Parkinson's disease. And to put it into context, imagine what your day would be like if we did not have these drugs available for treating the motor symptoms of the disease. So we have to be very grateful, I think, for what we have already, but certainly we can do better. Now, the best drug for treating Parkinson's disease is L-DOPA. Everybody who has Parkinson's disease will eventually need this drug. It comes in two standard forms, Sinemet and Matterpar, and most people with Parkinson's disease will take one of those two forms. Now, L-DOPA is not the easiest drug in the world to work with. It's not a very stable drug. It doesn't get through the gut very well. It doesn't stay around in plasma for as long as we would like to give you sufficient benefit. So it may not be too surprising that if we go and we look into the future, this is only a short list, 24 new versions of L-DOPA are currently under development. People are trying to make versions of the drug which last longer, versions of the drug which you can give by other delivery routes, not just as tablets. Maybe you could put them on the skin and they would pass across the skin. Other routes of administration and using technology to deliver L-DOPA. And I'm just going to show you one example of the sort of thing that can be done. This is a new version of L-DOPA, which in Europe is called Numient. In America, it is called Rytary. And I'll just emphasize why it's better. These are the plasma levels, the blood levels of L-DOPA you get if you take your regular form of Sinemet or Matterpar. You can see that these stay high for about 2 hours and then they fall away. And as they fall away, you lose the benefit of the drug. The drug stops working. With Numient, after one dose, the blood levels are maintained for much longer periods of time. And what that means is you get a longer duration of effect of each dose of L-DOPA that you take. And I can show you this in practical terms. This is what's called the UPDRS. This is a system for rating motor function in Parkinson's disease. Going down means motor function is better, and with standard L-DOPA in red, you go down, you get better, you stay better for a couple of hours, and then the effect of the drug starts to wear off. With Numient, or Rytary as it's called in America, The drug works, and what happens is you stay on and mobile for a much longer period of time. And it is being suggested that this drug will increase the amount of time you are on and mobile by about 2 to 3 hours every day. So this should be a significant advantage if you're somebody who's suffering from wearing off with your Parkinson's disease. The other thing we've been very good at is using enzyme inhibitors to make L-DOPA, levodopa work better. For a very long time, we've been using these two compounds, carbidopa and bensericide. These are what are called decarboxylase inhibitors, and they are present in Sinemet and Madapal. So everybody taking L-DOPA at the moment is taking one of those two compounds, and what they do is they stop L-DOPA being broken down in your gut and in your peripheral tissues, and they push more L-DOPA into the brain, which is what you want because that's where it's converted to dopamine and that's where it has its effect. More recently, some of you will have been taking either selegiline or another compound, rasagiline, which is sold as Azilect, and you would take that because it inhibits an enzyme called monoamine oxidase B, and this is an enzyme that breaks down the dopamine formed from L-DOPA. So this drug makes the dopamine from each dose of L-DOPA last for a longer period of time. Some of you will also be taking entacapone. That's either Comtan or Comtess. I can never remember what it's called in different countries. Or you might be taking that in the form of Stalevo. And this is another enzyme inhibitor that potentiates the duration of effect of each dose of L-DOPA. So we've been trying very hard to make L-DOPA work longer for you and work in a better fashion for you. But these compounds are also, they're not perfect. And the good news is there are some new compounds coming through which are better than the ones that we have already. For example, here is another compound like entacapone. This one's called opicapone. And the great thing about this compound is you only have to take it once a day. This is a very, very convenient drug. You will take it, in this case, you probably would take it last thing at night, and what it will do is it will prevent L-DOPA from being broken down as rapidly for the following 24 hours. And this drug is now registered in North America and also registered in Europe. I don't know when it will come here, but it is, again, a new treatment for Parkinson's disease which has advantages over older therapies. And this is what it's called in commercial terms. It's called Ongentys, and what has been shown is that in clinical trial, Ongentys will reduce the amount of off time that people have each day, and so what it does, it keeps you on and mobile for a significantly longer period of time than would occur if you just took regular Sinemet or Madapal. And here's another one that's coming along. This drug is a monoamine oxidase B inhibitor. So this is a drug like selegiline or rasagiline, but this drug has some differences. This drug not only prevents the breakdown of dopamine, but this drug has additional pharmacological activities. And we think that these additional pharmacological activities are very important because not only does this drug improve motor function, but it will decrease dyskinesia if you have any of those involuntary movements. And this drug also seems to have effects on pain, and it has effects on mood in Parkinson's disease. So although it's another small step forward, it's another tool with which your physician can try to treat various symptoms of Parkinson's disease which are currently not treated exceptionally well. And what we like about this drug, sulfonamide, is it's got what's called a half-life of 23.4 hours. What this means is this is also a once-a-day drug. So what we're trying to do is stop you having to take medication several times a day. What we're trying to do is give you convenience of taking drugs just once a day and having them work all day, which means you can get on with living your life. And we hope these drugs are going to improve quality of life for people with Parkinson's disease. The other thing we've got very good at is that we don't necessarily have new drugs coming through in Parkinson's disease, but we've got very effective at delivering old drugs using new technology. And this slide illustrates technology for delivering a dopamine agonist drug called apomorphine, which you can get in a pen, which you can give yourself as a subcutaneous injection, which is a rescue therapy. So if you feel you're turning off, you can just put an injection of apomorphine into your arm, and in 5 minutes you will have turned back on again and can continue whatever you were wanting to do. The drug can also be given by a continuous subcutaneous infusion. So you can have apomorphine being infused into your body for almost the complete day. And what this does again is it stops you swinging up and down in terms of movement. What it does is it smooths out the day and allows you to have greater controlled mobility. And greater controlled mobility means the ability to get on and do the things that you want to do in your life. And we can do the same thing with L-DOPA. You can have what's called duodopa. This is a little more invasive. It involves a tube going through the stomach wall and into the stomach, and then with a tip of a cannula in your small intestine, where levodopa is absorbed into the body. But levodopa can be infused over 12 or 14-hour periods of the day. So if tablets stop working for you, there are now alternative ways of treating the motor symptoms of Parkinson's disease, and you're going to see these types of technologies being increased, and you're going to see new technologies coming through on a regular basis. So let me show you this one. This is a system which comes from a small Israeli company called Neuroderm. They have invented a skin patch, so you just put a patch on your skin, and the patch is fed with either levodopa or with apomorphine from a small insulin-like pump. So you have a tiny little pump, and it's continually putting drug into the patch. The drug from the patch goes into your blood and then into your brain, and what this does, it gives you a way of having continuous drug treatment over the day that is not invasive. So there's no surgery, there's no needles involved in this. This, when it comes, will be a very, very effective way of treating you continuously over the period of every day. Now, you've probably heard from the previous talk, and probably from yesterday, that Parkinson's disease doesn't just affect the dopamine-containing neurons in the brain. I've got to see how much time I have over here. Okay, Parkinson's disease also affects various other neurotransmitter systems in the brain. And what this means is different parts of the brain degenerate, and those parts of the brain that are not using dopamine as a neurotransmitter are probably responsible for many of the non-motor symptoms that you might get, that you heard about earlier. So what we're trying to do is produce a new generation of drugs that don't act on the dopamine system, but act on other neurotransmitter deficits in the brain in Parkinson's disease. And I'm just going to show you one or two examples of things which are happening. This is the basis of what I've just been saying. If you look at the brain in Parkinson's disease, there is widespread pathology. that affects dopaminergic and non-dopaminergic neurons. And if you look in the bit of the brain that controls your movement, which is called the basal ganglia, dopamine is one important component of this system, but all the other bits of the basal ganglia that control your ability to move use other chemicals. They use acetylcholine, GABA, 5-HT, noradrenaline, many different chemicals. And what this does is it gives us a lot of opportunity for trying to produce drugs that act through different mechanisms to the ones we currently have, and which therefore may have advantages over the drugs currently used to treat motor symptoms. And this is one drug that actually we've used for quite a long time. This is a drug called amantadine. Amantadine acts on a neurotransmitter system that uses a chemical called glutamate. And what amantadine is good at, it is good at suppressing any involuntary dyskinetic movements that people might get. Now, the trouble with amantadine is it's a bit of a nasty, toxic drug. And at effective doses, many people do not tolerate the drug very well. So what's happened is an American company have brought out a new version of amantadine, a controlled release version of the drug, which has got the horrible name of Gocovri. And Gocovri is a version of the drug where you don't get so many side effects as a result of taking the compound, because they've altered the formulation such that the levels in your blood are not so high and so rapidly high to make you sick. Rather, the levels come up slowly. They control your involuntary movements over the course of the day. So this is an old drug, but this drug in this formulation may have significant advantages for treating some of you. But this is more exciting, perhaps. This is an image of the brain. This is a PET scan. And what this is imaging is something called adenosine A2A receptors. And the reason we're interested in these receptors is they are present only in the part of the brain that controls movement and the part of the brain that is disrupted in Parkinson's disease. So they form a very interesting target for a new class of drugs for Parkinson's disease that are not dopaminergic in nature. And this is the first of these compounds that has come into use. Now, this compound is called Neuriast, and at the moment it is only marketed in Japan for the treatment of Parkinson's disease. And what it does is it reduces very significantly the amount of time that you are off during the day. And it does that while you're taking L-DOPA. You get the maximum effect from your L-DOPA. If you take Neuriast, you get even more effect from L-DOPA. And this compound is looking very exciting because it doesn't have many adverse side effects. It's a very clean drug, so you get the effect you want without having any unwanted effects as a result of taking this treatment. Now, this compound will be licensed in America in the next 1 or 2 years, and then presumably it will spread into other territories, into Europe. I don't know how quickly it would come here, but I think this is going to be a very important addition to the treatment of Parkinson's disease. I won't show you that one. And this is one other I want to show you. This is another drug which is very interesting because this drug was originally developed as a drug for treating epilepsy. But this drug has some interesting pharmacology. It has some interesting actions as a drug which are highly relevant to Parkinson's disease. And again, in Japan, this compound has been repurposed, as we call it. It's been taken from epilepsy and it has been put into clinical trial in Parkinson's disease, and now in Japan it has a license for the treatment of Parkinson's disease because it can control motor function effectively in some patients with Parkinson's disease. So there could be other old drugs out there which will be very useful if we bring them from one medical indication into the Parkinson's disease arena. And having drugs that have more than one action is probably what's going to happen in Parkinson's disease. At the moment, we tend to give you one drug for this, and one drug for that, and one drug for something else. And what happens is you get a pill burden. You are surrounded by piles of tablets that you have to take each day. What we're trying to do now is to introduce drugs that have multiple pharmacological effects and will control multiple components of your Parkinson's disease. And this is to reduce the pill burden and allow you again to have better quality of life and have drug treatment that is taking care of all the parts of your Parkinson's disease and not just one part at a time. The last bit. I think I have about, let me have a little look at the clock, 7 minutes, okay. Instead of just treating the symptoms, why don't we try and do something about the disease itself? And what we can do is we can use neurorestoration, so we can try and put back the damaged dopamine system, we can try and put it back into the brain. We can try and modify the disease by slowing down the rate at which it gets worse, or we can try and neuroprotect you. And that means we give you something that stops the disease occurring in the first place, or will stop the disease even once it's been diagnosed. And we can do all of these things. And what I just wanted to emphasize is that there is a huge amount of activity going on to try and do something in this area. We can put new dopamine neurons, fetal neurons, into the brain. We can use stem cells to put back dopamine function. We can use viruses that we manipulate to produce dopamine and put them in the brain. We can use growth factors to try and stimulate the growth of the brain. And the point I want to make about this is all of these are in current clinical trial. All of this work is currently being tested to see whether it would be effective. We're also trying to design new drug molecules to stop the disease process completely. We're taking old drugs from other indications and doing this process of repurposing them into Parkinson's disease, and we're really trying to attack the final toxic step that we think kills nerve cells in Parkinson's disease. And again, the point of showing you this is every one of these approaches is currently under clinical investigation to look to see whether it will work for your Parkinson's disease. What we're trying to do is we're trying to develop processes, drugs that are based on the processes we think are responsible for Parkinson's disease. So we're looking at what changes occur in the brain. We're looking at things that are linked to some of the genetic causes of Parkinson's disease, and we're doing this process of repositioning old drugs that seem to have useful properties that may affect the disease process in Parkinson's disease. And the reason we're looking at old drugs and repurposing them is that you have to understand that from discovering a drug to having a medicine can take 15 years. And it's a very expensive process, and during those 15 years you can lose the drug at any point because it might not be effective, it might be toxic, it might not be, you might not be able to formulate it into a tablet in the way you want. So what we're trying to do is short-circuit that process by picking up drugs which are already in use in humans for other reasons. And this is not even a complete list. We are taking drugs from diabetes, from cholesterol-lowering drugs, drugs used to treat blood pressure, anti-cancer drugs, anti-malarials, iron chelators. We're looking at drugs in all of these classes as potential neuroprotective treatments for Parkinson's disease. And again, all of these are in clinical trial already. And all of this is ongoing, and there's some positive data already coming from the drugs which are used to treat type 2 diabetes. The final little bit. We believe that in Parkinson's disease, the final toxic step in cell death relates to this protein called alpha-synuclein, because when you look in the brain in Parkinson's disease, you find unusually high amounts of this protein in the nerve cells which are dying or already dead. And we believe this protein is very important. We know what happens, that this protein is made in the cells, and then it goes through a whole series of changes, and it gradually goes into clumps. It becomes sticky and it aggregates in cells. But during that process, bits of the protein, oligomers and protofibrils, are formed, and these have been shown to be highly toxic to dopamine neurons in the brain. So what we're trying to do is stop alpha-synuclein being formed. We're trying to stop its processing. We're trying to stop these toxic bits being formed. We're trying to remove the protein and the aggregates from brain. And again, in all of these areas, clinical trials are already underway to try and find a drug which will prevent the toxic actions of this protein in Parkinson's disease. But don't expect any one drug to work for everybody. People with Parkinson's disease are very different, and probably people with Parkinson's disease have the illness for many, many different reasons. So what we've got to try and do is find a drug that works for some people with Parkinson's disease first, and then find drugs that work for the other people with Parkinson's disease. So please don't expect that a single drug will come along and it is going to be the cure for everybody, because that's simply not going to happen. So the conclusions are that improvements in dopaminergic therapy are coming. Even though we've had dopaminergic drugs for 60 years, things are going to improve. Drugs that act in different ways, non-dopaminergic drugs, are also coming, and you will see them coming into treatment as a completely new approach to therapy. Treatment for non-motor symptoms is going to be dealt with by my colleague Professor Chowdhury after the coffee break, but you will get new treatments there. And progress is happening. You are going to get drugs that modify the disease process, but one of the things you have to be is, I'm afraid, you have to be a little bit patient, because these things take longer than any of us want. Thank you very much indeed.
Thank you very much, Professor Zhang.咁不如俾Professor Zhang嚟答一個問題先啦，呢個。So somebody asked about the cell-based therapies.
Yeah. Okay. This is a question which relates to stem cell approaches to treating Parkinson's disease, and it is certainly true that a clinical trial on stem cells has started in Australia. The difficulty with this trial is that we are uncertain about how pure the stem cells are that are being used in this study, and it's not something where I think we would recommend that you try to go to Australia to get this treatment. They have already implanted these cells into a few patients The difficulty is that you have to wait a very long time to make sure the cells are firstly effective, and secondly, you have to make sure that the stem cells have no adverse, serious side effects, because once you've had stem cells put into your brain, you can't go back in and take them out again. So these are irreversible procedures, and if there are long-term side effects to that treatment, it's going to be very difficult perhaps to deal with some of those side effects. So other stem cell trials are just about to start in Europe, and they will be using what are called pluripotent cells, and we're pretty certain that those are going to be the clinical studies which will decide whether or not this approach is a viable approach for Parkinson's disease.
頭先大家聽唔聽到個即時傳譯啊？要唔要簡單講一聲啦嚇？因為有個朋友就問咧，如果即係澳洲間公司咧有一個新嘅治療咧，係用一啲幹細胞嘅治療嚟嘅，咁係咪有效咧？頭先Professor JENNER就話咧，而家嚟講就唔建議啲柏友飛去澳洲接受呢個治療，因為呢個都仲係一個研究嘅階段嚟嘅，我哋係要好小心去，暫時嚟講都唔係好清楚知道佢個副作用係啲咩嘢，同埋咧另一個問題，如果我哋放咗啲幹細胞入個腦度咧，就唔係可以咁容易攞得翻出嚟嘅。如果真係萬一有啲乜嘢嘅問題出現咧，即係遲1-2年先出現咧，就可能會解決唔到嘅。但係呢個咧係其實唔止淨喺澳洲，喺歐洲亦都有啲研究咧係將會展開嘅。呢個係其中個治療咧，我哋希望可以咧係根治到柏金遜症。嗱，另外一個咧都係英文寫嘅，不過我可以講咗我答咗先，然後再俾Professor JENNER嚟答啦。佢問得係好好嘅問題嘅。佢話香港嘅腦神經科醫生治療柏金遜症有冇啲特定嘅方案？會唔會跟住一啲方案去開啲藥俾啲病人？同埋會唔會用到一啲新嘅功能上嘅造影去幫助？嗱，我答咗香港嘅腦神經科醫生點做先啦。然後問下Professor JENNER喺英國有冇類似嘅咧？Someone asked, do neurologists in Hong Kong or in UK follow a standard protocol in prescribing medications to patients with PD？ 嗱，呢個好嘅問題嚟嘅。不過咧，因為柏金遜症雖然咧個症狀大家類似，不過咧每一個病人佢遇到嘅問題同埋個嚴重嘅程度係唔同嘅，佢個所需要，佢對於活動能力個需要係唔同嘅。可以話咧，每兩個病人係絕對一樣，佢遇到嘅問題或者佢嘅需要係絕對一樣嘅。所以咧，以我所知咧，就好難有啲真係好標準嘅方案，話咧你第一年我哋俾咩藥，俾咩劑量，第二年俾咩藥，俾咩劑量。有一啲係我哋叫做指引啊，我幾時要開啲強啲嘅藥，幾時可以開其他嘅藥，或者當遇到副作用嘅時候點做法。咁當然我哋要對個病認識要多啲，同埋對啲藥亦都要了解多啲，知道啲藥有咩作用，有咩副作用，咁而係就住每一個病人去開一個適當嘅藥。咁至於用嗰個功能上，因為而家一般嘅造影咧，我只係可以咧排除其他原因引起，有啲好特別嘅造影咧，我哋就先可以幫助診斷柏金遜症，尤其是早期嘅柏金遜症。當我哋唔係好清楚知道係咪佢個症狀咧係柏金遜症啦，定係其他原因引起咧，嗰啲特別啲嘅造影咧可能會有幫助。但係呢啲幫助咧，暫時嚟講咧就唔係可以幫我哋決定用啲咩藥嘅。咁係幫我哋解決個有時個診斷上困難係多啲。咁至於個腦嘅可塑性咧，的確係咧個腦嘅可塑性係可以通過訓練咧係可以改變個腦嘅功能嘅。但係喺呢方面暫時嚟講，柏金遜症咧，我知道運動咧就一定對柏金遜症有幫助。而好多研究都睇到咧，運動咧係可以減慢個病嘅發展。但係咧暫時嚟講就唔係真係有啲program 或者有一啲特定嘅治療嘅方案係可以咧阻慢嗰個柏金遜症嘅發展。而好多研究其實而家做緊咧都係關於藥物嘅。頭先Professor JENNER其實都介紹咗好多唔同嘅藥物或者好多唔同嘅方法，佢希望可以咧係停到終止到柏金遜症嘅病變。咁 咁甚至乎咧係可以補充翻一啲已經損失嘅細胞。OK， Professor Chen，有冇啊
？This question was about whether we have a standard protocol for treating patients with Parkinson's disease. The answer is there are these what are called algorithms which say start here, try drug A, if drug A doesn't work, try drug B or drug C. But to be honest, we don't find these very useful because patients with Parkinson's disease are very much individuals, and when Professor Chowdhury speaks after coffee, I'm sure he's going to mention personalised medicine, and what we're starting to do is believe that we need a different approach to treatment for every individual patient with Parkinson's disease because their symptoms and their response to drugs and all the other things that they have are different from every other patient. So I think we're trying to move away from having any form of absolutely standard practice for how we treat patients. You might have certain rules like some doctors would probably avoid L-DOPA in early Parkinson's disease and use a dopamine agonist. Some doctors will use L-DOPA early in older patients but not a dopamine agonist. We have some rules, but in general we do it on an individual basis, and I think that's the way it should be. The other part of this question says, do we recommend supplements, excuse me, vitamins, etc.? I'm a scientist and I live and die by statistics. I do not know of any data that says these supplements have a good effect. But I don't know of any data that says these supplements have a bad effect. So what I usually say to people is if they feel that a supplement is doing them good and it's not doing them any harm and it's not too expensive, take it. If you feel it's of benefit to you, then you should continue to take supplements.
係頭先阿 Professor 將來另外答個問題就話建唔建議食一啲補充嘅，譬如維他命之類嘅嘢。咁但係咧，佢頭先阿 Professor 將來到而家為止咧，都冇一個科學上嘅證據咧，話一般嘅維他命或者啲補品咧係對柏金遜症嘅症狀好，或者對佢嗰個病理好係有個正面嘅影響嘅。但係咧，如果你食完嗰啲supplement 即係嗰啲補品，你覺得係有幫助嘅，咁佢亦都話你可以繼續食。
Well, we asked for questions and we've got them.
Yeah, we got a lot of questions. 因為呢個問題咧只越嚟越多啦，但我答咗一條問題先啦，然後咧就睇下 Professor Chen you may ask this later, so I answer the question first. OK， 咁有一個朋友就問咧，如果係點樣定一個體位性血壓低嘅定義係點樣？咁體位性血壓低咧，我哋通常咧，如果我哋嘅診斷咧就係去上壓，你坐喺度嘅時候度個血壓，然之後企喺度1至2分鐘度，我哋再度一次血壓。如果個上壓跌超過20，或者個下壓超過10，咁呢個咧就係體位性血壓低。但唔係所有人體位性血壓低咧，佢一定會有症狀嘅。不過好多時，如果佢一個病嚟到話有頭暈咧，尤其是已經個病有一段時間食緊啲藥咧，我哋第一樣嘢都要排除係咪一個體位性血壓低引起嘅。因為體位性血壓低咧，有啲有效嘅治療方法咧，可以減少呢方面嘅頭暈嘅，咁亦都可以減少個跌倒嘅機會嘅。
So this is a question about combinations of Sinemet and Requip. And the question basically is that this person was started on Sinemet 3 times a day for 2 years, and now Requip controlled release has been added to their treatment. Now, this is a strategy which I suspect is being used because the levodopa 3 times a day is not producing sufficient benefit, and there are fluctuations occurring over the course of the day. So it is a pretty standard practice to combine levodopa with a dopamine agonist. Not everybody would do this. Some people might increase the number of doses of Sinemet that they were giving the patient rather than adding a dopamine agonist, but that would probably depend on the age of the patient, the duration of their disease, and also their response to the drug. My own view is that dopamine agonists like Requip and Mirapex, pramipexole, are not as effective as levodopa, and so my inclination is to try and get control with levodopa as far as possible, but without giving excessive doses, because if you give excessive doses of levodopa, then there is a risk that you will start to develop dyskinesia as a result of those doses of the drug. So the question at the end says, should I progressively move towards more use of Requip? My own view would be I would be trying to maintain you with more levodopa rather than with more Requip. But it really depends on you as an individual and your response to the drug and your needs. And this is why there are no algorithms, there are no set procedures for how to do these things. It has to be done on a personalised, individual basis.
頭先有個問題咧，就話咧食完L-dopa 之後，即係左旋多巴之後，再加多巴受體激動劑就嗰個 Requip 啦。咁佢就話好唔好停咗嗰個左旋多巴？咁Professor JENNER 就話通常左旋多巴俾嘅效果咧就會有效過。一般嚟講會有效過多巴受體激動劑嘅，咁但係咧左旋多巴如果個劑量大，同埋咧持續食咧，有機會出現啲長遠嘅副作用。頭先講過藥效波動啦，同埋不自主動作啦。咁但係咧每一個人所需要係唔同嘅，咁佢都同之前嗰段問題係有啲類似嘅。我哋好難咧有一啲好硬性嘅方案話咧，一定係跟住醫藥隻藥用咗幾多 mg， 跟住下一隻藥用幾多 mg， 就好難有啲咁硬性嘅方案去用藥嘅。咁一定要睇翻病人嘅需要，佢自己嘅年紀啊，佢嘅職業啊，佢要幾多嘅活動能力，同埋對藥物嘅接受嘅程度，咁而調校最適合佢嘅方案。咁其實呢度咧亦都有另外一個問題咧，同頭先嘅問題咧係類似嘅，不過啱啱調翻轉頭，呢個病人咧就話咧佢食咗Roperidol同埋咧Salicylium，即係另外一隻藥先，咁然之後覺得效果唔好，就食左旋多巴啦。可唔可以停翻多巴受體激動劑，只係食左旋多巴？This is the opposite of the question. So they found levodopa is more effective.
Yeah.
Then he asked, can we stop the Roperidol and Salicylium?
Well, again, it really depends on how much effect these drugs are giving you. My own view is that with Parkinson's patients, we tend to keep adding drugs, and we don't usually start to take drugs away. It's not the philosophy we have, and often patients are very resistant to having any of their drugs stopped. My suspicion would be that the selegiline is probably only giving you a minor benefit, but people often feel better taking selegiline because it makes you a little euphoric as a result of taking it. But it's one of the things that you have to work out with your neurologist or geriatrician. You have to almost experiment with yourself under medical supervision to find out where the benefit from the drugs is coming from and what combinations of these drugs are going to give you the maximum benefit for your particular Parkinson's disease.
但頭先 Professor JENNER 都答咗類似嘅，即係話你每加嗰個藥咧，左旋多巴咧，肯定咧個功效係會明顯啲，會睇得到啲。但係咪可以停翻之前嗰兩個藥咧？咁一般嚟講咧，除非個病人食咗係 有唔舒服，即係有啲副作用你接受唔到，或者好明顯嗰啲藥咧完全一啲幫助都冇嘅。咁好多時你停咗另外啲，譬如多巴胺受的激控劑咧，你有可能咧係需要左旋多巴個劑量會大啲嘅。咁其實咧你停咗藥嗰時咧就發覺佢其實都幫到你啲，唔係完全冇幫助嘅。點樣去調教個藥物係最理想嘅話咧，咁就真係要個個人會唔同嘅，要逐個人逐個病人咧去做評估，先至可以知道得到嘅。咁同呢個有關嘅話咧，有啲跟進嘅話咧，就收到個兩個問題啦。就問，既然左旋多巴會出現一啲長遠嚟講會出現一啲副作用，緊要嘅副作用，或者係出現一啲抗藥性，我哋唔可以要抗藥性嘅，個效果冇咁好，好唔好？我哋遲啲先至食。有病開始唔食住先，遲啲先至食。咁其實呢個問題咧喺醫學上咧都已經係咧研究咗好耐，亦都有爭論咗好耐。咁但係好多新嘅研究其實咧都發覺咧，如果你個病情到某個程度，你早啲開始食左旋多巴，係其實咧長遠嚟講係有幫助嘅。雖然左旋多巴係會有長遠有佢嘅副作用，個效果冇開頭食咁好，但係咧。如果你早啲開始食左旋多巴，同埋開頭唔食，你夾硬捱幾年之後咧，發覺幾年之後早啲開始食左旋多巴嘅病人咧，反而咧佢嗰個活動能力，佢嗰個症狀咧係控制得仲好啲嘅。所以一般嚟講咧，我哋就唔建議，因為個藥有副作用，所以咧就唔開始食藥。These two questions are quite similar. They ask about, so we know that in long term, levodopa have a lot of problem, and the effectiveness will reduce. Then should we withhold the drug for a couple of years, and then we start the drug later?
Okay. Now, this is a fairly difficult question. It's about when should I start levodopa, Sinemet, Matapar treatment? Should I wait because it is the best drug? The difficulty is that if you start levodopa early, you might get a honeymoon period, a window of good effect that is this big. If you wait, the window doesn't go down the disease and is of the same duration. The window of good effect becomes shorter, because the more advanced the Parkinson's disease, the shorter the duration of good effect that you will get. So the current philosophy now is not to wait to use levodopa, but to use the drug sensibly and in relatively low doses early in the disease. And we've sort of gone from the introduction of L-Dopa 60 years ago. It was used in very high doses. People got lots of dyskinesia, and so what happened then was people said, we wait with levodopa, we use a dopamine agonist first, and then we add levodopa. But now the whole thing has turned around, and we are back to using levodopa early, but in a sensible manner, and not using as high doses as were used originally.
Professor 真係答同我頭先講類似啦，即係而家好多證據咧就話咧，我哋唔應該係話遲啲先至開始用左旋多巴，雖然知道長遠有副作用嘅，咁但係咧我哋就要小心啲用，同埋咧就唔好一味係咁加個藥。好早時候如果左旋多巴唔夠嘅話咧，我哋就早啲開始加埋多巴胺受體激動劑或者其他嘅藥，就唔係淨係一味將個左旋多巴嘅劑量加大去。仲有好多問題，我答邊條先？You're
overrun with questions.
我哋可以嗱，因為而家已經係夠鐘啦，幫我哋答多2、3條問題啦。似乎我頭先話想答晒啦，原來唔得嘅，因為越嚟越多。而家台面仲有成超過20條未答嘅。咁我哋睇下好啦，呢個咧就一個病人咧，就一個朋友就問咧，如果當有病步太僵硬、冷凍嘅時候，即係 freezing 嘅時候，係點樣做法？係咪即刻要停咗唔行咧？咁呢個其實係嘅。如果當佢隻腳唔喐嘅時候，你夾硬行咧就好易跌嘅。好多時同病人講咧，如果佢咧突然之間行下，隻腳唔識喐，我哋叫做步態冰凍啦，或者係 freezing 啦，你就應該即刻停喺度。咁嗰陣時要睇下你係啲藥到定係啲藥唔到。 嘅 freezing。如果藥到都係有 freezing 嘅話咧，咁你加多啲食藥落去咧，係未必有幫助嘅。咁我哋用一啲視覺嘅提示、視覺信號，或者啲聽覺嘅信號，你自己數節拍，或者咧，大家唔知有冇攞過一支係激光拐杖咧？一個激光拐杖咧就俾一個視覺嘅信號，跟住嗰個信號去做咧，就可能可以咧解到凍，解除咗你嗰個 freezing 嘅問題。咁呢個下一節咧，可能咧Professor Chaudhary 咧會詳細啲再答呢個問題嘅。呢個另一個朋友咧就問咧，而家頭先Professor JENNER介紹個皮下注射嘅左旋多巴，佢就問咧係咪已經喺香港有用？已經係香港可以有得用，似乎就未得。
Well, I think the first part of this you might be able to answer. It says basically when is duodopa? Is duodopa?
No,
duodopa is apparently not available yet in Hong Kong. Do you have infusions of apomorphine?
Yes.
So infusions of apomorphine can be used, and that's the subcutaneous infusion of the drug. In my country, we find this to be very effective in patients who are no longer getting sufficient benefit from oral drug treatment. The only problem in my system is this is expensive, and so the number of people who can take advantage of that type of therapy is fairly limited. When Professor Chaudhary gets here, you should ask him about apomorphine, because his centre is a specialist centre for using apomorphine, and I'm sure he will be able to tell you more than me about the benefits of that treatment.
Okay. 好，關於皮下注射咧，如果係左旋多巴嘅皮下注射，或者係直接注射入去個十二指腸啦、個 duodenum 啦，暫時嚟講香港就未有呢個藥嘅。喺歐洲咧就會有用，喺美國、歐洲就有用，但係呢個用起上嚟咧，其實咧就有好多其他方面嘅配合。咁如果係皮下注射嘅藥咧 ，apomorphine 咧，香港而家都有，亦都有唔少嘅病人咧係用緊 apomorphine 嘅皮下注射。咁可能佢除咗幫助咗嗰個運動功能之外咧，其他嘅非運動嘅症狀咧，咁 apomorphine 咧可能都會有幫助。因為下一次嘅咧另一位講者咧，應該嚟個講者咧 Professor Chaudhary 咧，佢就將會詳細啲再介紹呢個 apomorphine 係點樣。咁呢個咧一個好嘅問題嚟，不過我諗亦都未必有個好嘅答案，即係擔心。佢就話咧，佢而家咧係喺初期柏金遜症嘅初期，有冇方法可以延遲去進入一個中期？ So the patient asks, is there any treatment that is effective to delay the progression from first stage to second stage?
At the moment, there are no treatments which have been shown to be effective in delaying the progression of Parkinson's disease. So there have been a lot of clinical studies, but so far none of these have been successful. And one of the reasons they may not be successful is that we are not looking at the individual patients in those studies. We're just treating everybody as a large group. And we have the feeling that because, as I said at the end, there is not going to be a single treatment that will work in anybody, that we may have missed some successful drugs in those clinical studies, and we need to go back and look and see whether, let's say, 10% of patients did get better, but we didn't see them against the 90% who were unaffected by that drug treatment. So at the present time, the answer is depressingly there is nothing which has been shown to be effective so far, but you should take hope from the tremendous amount of activity that's taking place at the moment to try and find a treatment. And I've been working in Parkinson's disease for nearly 40 years, and I have never seen a time when there was so much activity, and some of that activity is certainly going to produce drugs which will be of benefit on the disease process. My suspicion is the first ones will be drugs that slow down the rate at which progression takes place.
頭先Professor JENNER 到目前為止咧，都未曾有一啲經科學上證明係確實有效，可以咧減慢嗰個病情嘅發展。不過咧，佢亦都俾一個好正面嘅消息我哋咧，佢話咧，佢從事呢個柏金遜症藥物研究超過40年啦。佢就話而家過去呢幾年咧，佢從來未見過咧有咁多研究係正在做緊嘅。咁多唔同嘅國家、唔同地方做咗研究，係針對點樣去減慢柏金遜症嘅發展。咁佢話好相信咧，好短時間之內咧，將會有啲研究咧係會成功，係可以咧係減慢，確實咧有效咁減慢個柏金遜症嘅病情嘅發展嘅。我哋已經過咗10分鐘啦，大家仲想答問題啊？定係要休息一陣間？因為咧下一個環節咧就將會15至20分鐘就開始下一個。下一個另外一個係會好精彩嘅，就係關於點樣我哋去應付一個柏金遜症嘅非運動嘅障礙。
We have to stop, do we?
可能我答最後一個問題啦，呢個可能大家都有啲關心啊。So maybe I last questions。有個朋友就問咧，佢食咗柏金遜症一段時間，停咗去轉食其他藥，建唔建議咁樣做法？所以someone asked whether other alternative medicine is as effective as medications, proven alternative medicine. You say herbal medicine. Do you recommend take herbal medicine or some alternative medicine?
Yeah.
To replace the levodopa.
Right. At the moment, none of the new drugs which are being developed will replace levodopa. But what you are going to get are drugs that will work in conjunction with levodopa to give you even more benefit than you get at the moment. And these new drugs will also avoid some of the side effects which are common with levodopa, because you will probably be able to use a lower dose of levodopa in conjunction with these new drugs. So this is going to be a new era of drug treatment, and I think it's going to be of very significant benefit to a lot of the patients who currently experience unwanted side effects from their dopaminergic medications.
OK， Professor 真係就話其實而家有好多新藥咧，就即將會係免費咧，係可以咧，我哋用少啲左旋多巴係增強左旋多巴嘅藥嘅藥效，咁而會減少佢嘅副作用。咁我建議咧，大家咧就服用一啲係經科學證據有效嘅藥，同埋咧第時咧會有其他嘅藥咧係可以咧減少左旋多巴嘅副作用，同埋減少佢個劑量，就唔好咧就停咗個藥。頭先好早之前都介紹過，咁其實好多研究咧就話咧，你早啲開始服用左旋多巴咧，其實咧長遠嚟講，幫到呢個病情咧係更加有效嘅。咁我哋都過咗15分鐘啦，咁可能我哋而家呢個環節咧喺度要停啦。咁唔好意思，就仲有好多問題知道咧，仲有好多問題係答唔到嘅。咁如果第日有機會咧，大家再嚟參加我哋呢個公眾研討會，可以再解答大家問題。多謝大家。咁我最後要多謝Professor JENNER添。
Okay, thank you very much. Thank you very much. Okay, thank you.